this video, we are going to discuss on the topic hypovolemic shock. So as the name indicates, hypo means decrease and volemic means volume. So when there is decrease in the volume of blood or fluid in the body, it can lead to hypovolemic shock. It depends upon the amount of blood or fluid lost in the body. So let's move on to the definition. It is a life-threatening decrease in intravascular volume leading to inadequate perfusion and oxygenation of tissues. So basically, when there will be decrease in the blood volume, so the organs will not get enough supply of the blood, and due to that there will be hypoxia in the tissues and there will be lack of oxygenation in the tissues. So that's why here we say there is inadequate perfusion and oxygenation of the tissues. Now let's see what can be the reasons of blood or fluid loss. So let's talk about the fluid loss. It can occur due to vomiting or burns or ascites. It can occur due to diuresis or diarrhea. So in all these conditions, there is loss of fluid from the body. If we talk about burns, when there is burn in the patient, there is lots of fluid loss from the body. And in ascites also, the fluid shifts from intravascular space into the extravascular space, which leads to decrease in the blood volume or fluid volume. Talking about in the blood loss, it can occur due to any surgery. So during any operation, there can be massive bleeding which can lead to blood loss. And other can be any trauma. So any roadside accident and any kind of trauma can lead to blood loss. Now, when there is decrease in the blood volume, this leads to decrease in the venous return to the heart. So what is venous return? So it is the flow of blood from periphery to the right atrium. So as we know, when the blood is circulated in the body, it goes back into the heart, that is into the right atrium. So this is venous return. So when there will be decrease in the blood volume, this will lead to decrease in the venous return. And this decrease in the venous return to heart will lead to decrease in preload. Now what is preload? It is a feeling pressure of heart at the end of diastole. So when the blood returns back into the heart, it fills in the atrium and ventricles. So when the heart is in diastolic condition, it exerts a pressure, that is the filling pressure, and at the end of diastole, the pressure it takes to fill is known as preload. So when there will be decrease in the blood volume, decrease in the venous return to heart, so there will be decrease in the pressure in filling the blood into the heart. So that's why there will be decrease in the preload. So decrease in the preload will lead to decrease in the cardiac output. So all these things are eventually related to each other. So when there will be decrease in preload, that will lead to decrease in the cardiac output, which means that there will be not enough blood to take out from the heart and to supply all over the body. So all these conditions will eventually lead to decrease in the blood pressure. So there is no enough blood in the arteries, and that's why there will be decrease in the blood pressure. Now, what are the other things that will happen in the body? So when there is decrease in the cardiac output, heart is trying to supply adequate blood to the organs. So this will lead to heart rate increase. So basically, when there is decrease in the blood volume, our heart will try enough to give blood to the organs so it will beat fast. That's why the heart rate will increase. Now we will end this discussion and we will start MCQs after seeing the interventions. So what can we do when we see that there is hypovolemic shock? So the first immediate intervention will be we have to insert two large IV bore cannulas. So basically 2 large IV bore cannulas, that is maybe of 20 gauge, are inserted so that we can rapidly infuse the blood or the fluid into the patient's body. It depends upon the traumatic condition, whether it is roadside accident or whether it is fluid loss, burn. According to that, we will give the fluid. Second, we will start the IV fluids. Third, after doing the immediate intervention, we will monitor the vital signs. We will check if heart rate is not increasing, if level of consciousness is good or not, and also the urine output, because hypovolemic shock can eventually lead to dysfunctioning of the kidney. So we have to look for the urine output, and urine output should be more than 30 ml per hour. So all these things we will discuss later in the questions. After monitoring all these things, in the last we will send the investigations, like to check the hemoglobin hematocrit by CBC. We will check the kidney function test. We will do the ECGs, because in hypovolemia, potassium and sodium influx outflux can be suffered. So we can check if there is any cardiac condition, and serum lactate. So we will study about the serum lactate in the MCQs and ABG analysis. Now let's move on to the question sessions. So the first question is, a patient with severe dehydration and a heart rate of 120 beats per minute, blood pressure of 80/50 mmHg and cool clammy skin is being evaluated for hypovolemic shock. Which laboratory findings supports this diagnosis? So in this question, we can see a scenario that a patient with severe dehydration, which means that patient is totally dehydrated, has a heart rate of 120 beats per minute. So we have to know the normal range of the heart rate. So here the heart rate is 120 beats per minute, blood pressure is 80/50, and patient is showing the symptoms of cool and clammy skin. Now this patient is being evaluated for hypovolemic shock. So we are seeing if all the symptoms are related to hypovolemic shock or not. So what are the laboratory findings that will support our diagnosis? So the first option is serum sodium of 130 milliequivalent per liter. Option B, metabolic acidosis confirmed by arterial blood gases. Option C, serum lactate of 3 millimole per liter. Option D, mixed venous oxygen saturation greater than 80%. So what could be the symptom, what could be the sign, and what could be the test that will support that our patient is in hypovolemic shock? So as we see in this question that heart rate is 120 beats per minute. 120 beats per minute shows tachycardia. Blood pressure is 80/50, which shows hypotension, and cool clammy skin. Now here the cool and clammy skin is due to the blood is withdrawn from the peripheral organs to the major organs like brain, lungs. That's why skin appears cool and clammy. So when our heart is trying hard to supply the blood to the important organs like brain, lungs, so in that condition the blood will be withdrawn from the peripheral organs, and because there will be less amount of blood, so the skin will appear cool and clammy. Now talking about the laboratory findings mentioned in the MCQ. So first is serum sodium 130 mg per milliequivalent. Now we should know that the normal serum sodium level is 135 to 145 milliequivalent per liter. But here the sodium level is 130, which means it is hyponatremia. So, in hypovolemia, as the blood volume is very low, therefore the electrolytes concentration will increase. So, in hypovolemia, we will not see hyponatremia, but we will see hypernatremia. So, serum sodium level will increase in hypovolemia. So, we will see serum sodium more than 145 milliequivalent per liter. Second is metabolic acidosis. So in the MCQ, it is shown that patient is having metabolic acidosis. So this supports our sign and symptoms of hypovolemia or not, we have to see. Now, when patient is in hypovolemia, that will lead to decrease of oxygen in the tissues. So that will lead to hypoxia of tissues. Now, hypoxia of tissues will lead to anaerobic respiration. Now, what is anaerobic respiration? So, when cells are not getting enough oxygen, they start anaerobic respiration, that is without oxygen. And due to anaerobic respiration, there is formation of lactic acid. So, lactic acid is developed in the body, and as the name indicates, lactic acid, so there will be acidosis, that is metabolic acidosis in the body. That's why in hypovolemic patient, we will find metabolic acidosis. Now, third option says serum lactate 3 millimole per liter. So as we discussed earlier, that lactic acidosis will develop in the patient's body. So this will appear in the blood. So serum lactate will increase in the blood. Now the normal range of the serum lactate is less than 2 millimole per liter. But in the case of hypovolemia, the level will increase more than 4 millimole per liter. So as the question says that serum lactate in the patient body is 3 millimole per liter, it does not support the hypovolemic shock condition. So this is not seen in hypovolemia. Now fourth investigation that is mentioned is SpO2 more than 80%. So what is SpO2? It is mixed venous oxygen saturation. It tells about tissue oxygen extraction. So what amount of oxygen is extracted from the tissue is mixed venous oxygen saturation. So in the normal person, the SpO2 is 60 to 80%. But in hypovolemia, as there is decrease in the oxygen level in the blood, so it will decrease less than 60%. So in hypovolemia, it will be less than 60%. So the correct answer is metabolic acidosis confirmed by arterial blood gases. Now moving on to the next question. A trauma patient arrives in the emergency department with a blood pressure of 90 by 60 mmHg, heart rate of 120 beats per minute, and cool, clammy skin. The nurse suspects hypovolemic shock. How much blood loss is required for hypovolemic shock to occur? Now, to solve this question, we should know the categories of blood loss or the classes of blood loss. So when blood loss happens in any person, it can be in different ranges. So this question wants us to ask that how much blood loss should be there so that we can consider it as an hypovolemic shock. So option 1 says less than 30%, option 2 more than 25%, option C more than 15%, and option D more than 10%. So what is the minimum amount of blood loss that should be present to show the signs of hypovolemic shock? So let's find out through this table. So in class 1 of the blood loss is less than 15%. Now, when blood loss is less than 15%, our compensatory mechanisms maintain the perfusion. It means that if blood loss is less than 15%, then our body can easily deal with it and there are no signs and symptoms of hypovolemic shock. But whereas when there is class 2 of blood loss, in this blood loss there will be 15 to 30% of the loss of blood. So in this we can consider this category as the hypovolemic shock. But here the symptoms that will appear are tachycardia, tachypnea and mild hypotension. So here also our body is trying hard to maintain the normal rhythm in the body. That's why there will be mild hypotension, mild tachycardia and tachypnea. Talking about the class 3, here the blood loss will be 30 to 40%, and due to that much of blood loss there will be marked hypotension and there will be mental status changes and weak pulses as the blood will be withdrawn from the periphery to the major organs, so there will be weak pulse. In class 4, the blood loss is more than 40%, so it will lead to severe hypotension, inuria, that is absence of urine, and multi-organ failure. So these are the categories of blood loss. Now moving back to the question, they want to ask that how much blood loss is required for hypovolemic shock. So first option says less than 30%. So as we know that 30% blood loss can be a major blood loss and signs and symptoms will appear. So it is a misleading term and it does not show the minimum amount of blood loss. Second is more than 25%. In this option also, blood loss symptoms, that is hypovolemic symptoms, will be seen, but it is not the minimum. Third is more than 15%. Now this is the exact answer. So more than 15% of blood loss should be there to show the signs and symptoms of hypovolemic shock. And fourth is more than 10%. So in 10% blood loss, that is less than 15%, there will be no such changes or no hypovolemic shock symptoms. So shock can occur as early as 15% of the blood loss. If blood loss is less than 15%, compensatory mechanisms are effective. Patient may just feel weak or dizzy but will not be in clinical shock. So the correct option is C, that is hypovolemic shock begins when at least 15% of the total blood volume is lost. At this stage, compensatory mechanism, that is tachycardia, vasoconstriction, starts failing, leading to hypotension and decreased tissue perfusion. Now moving on to the next question, question number 3. A patient who is experiencing hypovolemic shock has decreased cardiac output, which contributes to ineffective tissue perfusion. The decrease in cardiac output occurs due to Before that, I hope there is no confusion in the previous question. So you can see that in hypovolemic shock, which is less than 15%, there will be no sign and symptoms that will be major. But if loss is more than 15%, then we will consider it as hypovolemic shock, and here when the hypovolemic shock begins. So as we were discussing question number 3, here a patient is experiencing hypovolemic shock and has decreased cardiac output, which contributes to ineffective tissue perfusion. The decrease in cardiac output occurs due to option A, an increase in cardiac preload, option B, an increase in stroke volume, option C, a decrease in cardiac preload, option D, a decrease in cardiac contractility. So what could be the correct option? So as we know that we have discussed earlier that when there will be low blood volume in the heart, so the cardiac output will decrease. So what is the reason that the cardiac output is decreasing? So here we have to understand the pathophysiology. So basically, hypovolemic shock, which can occur due to hemorrhage, dehydration or fluid loss, this will lead to depletion of the blood. Now this depletion of the blood will lead to decrease in the venous return. So the volume of blood returning to the heart will decrease, and this decrease will lead to decrease in the preload. So as we have discussed earlier that when there will be no enough blood going back to the heart, so the heart will fill the blood, but there will be no much pressure to fill the blood. So when there is end of the diastole, which means when there will be preload, so due to less volume of the blood, preload will be reduced. That is, the ventricles will not stretch enough to fill the blood. So due to this will directly impact the stroke volume. So what is the stroke volume? It is the amount of blood ejected from heart from each cardiac cycle. So it is basically related to each other. So when there will be decrease in the blood from the venous return, so the ventricle will be not able to fill up properly, and that's why the heart will be not able to take out or eject out the blood, enough amount of blood from the heart for each cardiac cycle, and this all will lead to decrease in the cardiac output. So what is the cardiac output? This is the amount of blood that is ejected by the heart and that is circulated all over the body. So basically, when there will be decrease in preload, decrease in stroke volume, it will lead to decrease in the cardiac output. So now from these options, we can see an increase in cardiac preload. But when the cardiac preload will be increased, it means that there is enough blood in the heart. And when there will be increased preload, it will lead to increased cardiac output. So this option is not correct. Option B is an increase in stroke volume. So in this also, when stroke volume is increased, it means that there is sufficient blood in the heart. So in this case also, cardiac output will be increased. Option C, a decrease in cardiac preload. So this is the correct option, as there is hypovolemic shock, so there will be decrease in the cardiac preload and eventually decrease in the cardiac output. Option D is a decrease in cardiac contractility. Now we have to understand here that whenever the blood is going through the heart, in that case the contractility will increase. The blood in the arteries will exhibit a pressure. There will be increase in the resistance so that the blood can go forward, and there will be enough pressure to make the blood flow forward with the pressure. Therefore cardiac contractility increases, and this cardiac contractility increases because of the SNS, that is sympathetic nervous system. So the correct option will be a decrease in the cardiac preload. Now moving on to the next question. During what stage or class of hypovolemic shock does the sympathetic nervous system attempt to maintain cardiac output? So in this question, we have to understand that what are the stages of the hypovolemic shock. So as we have discussed earlier that there are different stages, different categories of hypovolemic shock according to the blood lost. So it depends upon the amount of blood lost from the body. So in this question, we have to see that what is the stage where SNS activates and it attempts to maintain the cardiac output. Is it the stage 1, stage 3, stage 4 or stage 2? So let's move on to the stages or classes of the hypovolemic shock. So as we have discussed that in stage 1, there will be loss of 15% less of the blood volume. So less than 15% of the blood volume will be lost. And in category 2, 15 to 30% of the blood volume will be lost. That is about 750 to 1500 ml. In third category, the blood volume loss will be 30 to 40%. That is about 1500 to 2000 ml of the blood. And in stage 4, the hypovolemic shock will be most severe because the blood loss will be more than 40%. So 40% and more of the blood loss will be there. That is about 2 liters, more than 2 liters. So what will be the different signs and symptoms, different physiology in the body happening in the various stages? So let's talk about stage 1. So in the stage 1, the body can deal the hypovolemic shock by itself. It means that here is no need of SNS to activate because the compensatory mechanisms are still adequate, which means that there will be no significant increase of heart rate, significant increase in the heart rate and decrease in the blood pressure or increase in the respiratory rate. So body can maintain normal cardiac output and tissue perfusion with this compensatory mechanism. Whereas in stage 2, the SNS is going to activate, which means the sympathetic nervous system will start activating. The adrenaline and noradrenaline will release and there will be increase in the heart rate, increase in the peripheral vasoconstriction and contractility of the heart. So, SNS activation is essential for maintaining perfusion to vital organs, though tissue perfusion may be still insufficient. So, when the blood loss is 15 to 30%, the SNS system will activate and there will be mild to moderate symptoms we will see. In stage 3, where the blood loss is 30 to 40%, the cardiac output falls significantly as it is a huge amount of blood loss, near to 50% of blood loss. Okay, so that's why there will be significant decrease in the cardiac output. And now the compensatory mechanism become overwhelmed. It means that there is no much efforts from the compensatory mechanism. And here the SNS is still active, its ability to maintain perfusion will decrease, which means that in stage 3, sympathetic nervous system is not helping much. So it will lead to worsening hypotension and organ hypoperfusion. So in this stage, there is immediate need of the fluid restoration. In the stage 4, when the blood loss is more than 40%, the SNS totally fails, and this leads to persistent hypotension, tachycardia, irreversible shock without immediate intervention. The body is no longer able to maintain adequate cardiac output or perfusion. It means that SNS will not be able to compensate and our body will not able to fight this loss of blood or fluid so that there will be many more and severe symptoms seen in this stage. So we have to remember these all 4 stages. In stage 1, there will be no SNS activation as body is compensating by itself. In stage 2, there is SNS activation. In stage 3, SNS is still active but the condition is not getting that much stable. And in stage 4, SNS totally fails and there are severity of symptoms. So, as we move on to the options, we have seen that option were stage 1, stage 3, stage 4 and stage 2. So the correct option is option D, that is stage 2. So in stage 2, we will see sympathetic nervous system activation. Now moving on to the next question. You are caring for a patient who has lost 45% of their fluid volume and is currently in hypovolemic shock. The patient is under hemodynamic monitoring and efforts to restore fluid volume are being made. Which of the following findings suggest the patient is still in hypovolemic shock? So here patient had 45% of the blood loss, which is a huge amount, and patient is in hypovolemia. Now in previous question we have seen that when there is the blood loss more than 40%, that is more than 2 liters, then SNS compensation fails and we have to do immediate interventions to reverse the condition, otherwise patient will go into the shock. Which of the following findings suggest the patient is still in hypovolemic shock? So the hemodynamic monitoring is going on, the fluid volume is restoring, but still how we will know that patient is not improving, patient is in hypovolemic shock? Option 1 says decrease central venous pressure. Option 2 says increase pulmonary artery wedge pressure. Option C says increased mean arterial pressure. And option D says decrease systematic vascular resistance. So what could be the correct option that will indicate that patient is not improving? So as we can see, patient is in hypovolemia. Blood loss is more than 45%. It means that there is decrease in the blood volume in the body. So let's talk about option 1. A low central venous pressure. So we can see patient is in hypovolemia, blood volume returning to heart is insufficient, and hypovolemia will lead to lack of circulating blood. So that's why central venous pressure will decrease as a result of low preload. So if central venous pressure is low, it will suggest that fluid restoration is still less, which means patient is still in shock. So are you able to understand that if central venous pressure is low, it means that fluid restoration is not done enough. It means that patient is not improving. Option B says increase pulmonary artery wedge pressure. So what is pulmonary artery wedge pressure? So it is a pressure that is exhibited by the pulmonary artery to carry the blood. So the increased pulmonary artery wedge pressure shows that there is fluid overload. If it is increased, it means that there is enough amount of blood or increased amount of blood, and it can indicate the left heart failure. But whereas in hypovolemic shock, as the blood volume is decreased, so the pulmonary artery wedge pressure will also decrease. It will not increase. If it is increasing, it is related to the pulmonary condition. It does not signify any hypovolemia condition. So increase in pulmonary artery wedge pressure can be due to fluid overload or left heart failure. It is not related to the hypovolemic shock. Option C says increase mean arterial pressure. So what is the mean arterial pressure? So it is the average pressure in the arteries. If there will be more blood, there will be more pressure in the arteries. But in hypovolemic shock, there is less blood, insufficient circulating volume. So MAP will be also low. So if mean arterial pressure is increasing, it means that patient is improving. But in question, we are asked about the signs and symptoms that show that patient is not improving. It means that mean arterial pressure will be low in the patient who is still in the shock. Option D. Option D says decrease systematic vascular resistance. So what is systematic vascular resistance? It is the resistance the heart has to overcome to pump blood through the arteries, reflects the degree of vasoconstriction. So basically, when the heart is pumping the blood, there is a resistance exhibited by the arteries. It reflects the degree of vasoconstriction, how much constriction is happening to move the blood forward. In hypovolemic shock, blood is trying to maintain the blood pressure by constricting the blood vessels, which results in high systematic vascular resistance. So in hypovolemia, the systematic vascular resistance will be increased because the blood is trying hard to maintain the blood pressure. So from all this discussion, we can finalize that decrease in central venous pressure shows and suggests that patient is still in hypovolemic shock. So option number A is correct. Now moving on to the next question. During what stage of shock does the body attempt to utilize hormonal, neural and biochemical responses to maintain the perfusion? Now this is the new thing that we have to study here. So we have discussed the stages of shock. Stage 1 is when the blood loss is less than 15%. Stage 2, when blood loss is between 15 to 30%. Stage 3, when blood loss is 30 to 40%, and stage 4, when the blood loss is more than 40%. In stage 1, there will be compensatory mechanism. In stage 2, SNS will activate. In stage 3, SNS will be still activate, but there will be signs and symptoms of the hypovolemia, that is tachycardia, tachypnea, low heart blood pressure. And in stage 4, when everything will fail, then there will be symptoms of shock. Now, these are the new names of all these stages: refractory stage, initial stage, proliferative stage or compensatory stage. So in which stage of shock there will be hormonal, neural and biochemical responses to maintain the perfusion. So the first stage of shock is initial stage of shock. This is cellular and silent. There is no outward symptoms or very subtle changes. There will be mild tachycardia, slight increase in the respiratory rate. It means we can relate that the blood loss will be less than 15%. Only in that condition there will be slight increase in respiratory rate or slight increase in heart rate, like 80 to 90 beats per minute. So there will be cellular and silent stage. Now stage 2, that is compensatory stage of shock. In this stage, the body activates its defense mechanism, that is compensatory responses. It tries to maintain perfusion to vital organs, that is brain and heart, at the expense of less critical organs, that is skin, GI tract, kidneys. So in this, as the stage name is compensatory stage, there will be activation of the defense mechanism and there will be more flow of the blood towards the vital organs. So in this stage, we will see the activation of SNS. It will release ADR and non-ADR. So heart rate will increase, contractility will increase and vasoconstriction will be there. The second thing that will occur is the activation of RAS, that is renin-angiotensin-aldosterone system. Now why there is need of RAS here? Because we need to increase the blood pressure. So by the renin-angiotensin-aldosterone system, there will be increase in the blood pressure. There will be sodium and water retention to maintain the blood volume. And the blood will be redirected away from the non-vital organs to preserve blood flow to the heart. And as the oxygen demand increases, respiratory will be increased. So in stage 2, we will see that there will be tachycardia, there will be tachypnea, and we will see the activation of SNS and RAS. Now, what will be the sign and symptoms? There will be tachycardia. To improve cardiac output, there will be increased respiratory rate to compensate for lactic acid buildup. So as there was anaerobic respiration and lactic acid buildup, So the increased respiratory rate will help in delivering oxygen to the tissues. The skin will be cool, clammy, and pale due to blood being shunted away from the skin. There will be decreased urinary output, less than 30 ml per hour, due to reduced renal perfusion. So you have to remember that in compensatory stage, we are trying to compensate. We are trying to do everything so that we can restore the blood. So there will be decrease in the urinary output, and the bowel sound will be hypoactive to reduce the GI blood flow. And there can be mild confusion or restlessness due to decreased cerebral perfusion. Now let's talk about the next stage. So the third stage is progressive stage of shock. It means that shock is progressing and the compensatory mechanism here is failing and tissue hypoxia is severe, and this is leading to the dysfunction of the organs. That is, multiple organ dysfunction syndrome can occur here. So this persistent hypoxia due to lots of blood loss, there will be anaerobic metabolism worsening, severe lactic acidosis. Capillary permeability will increase. It means that fluid will leak into the surrounding tissues. Edema and intravascular volume will be lost. Sodium potassium pump failure will be there. This will lead to dysfunctioning of heart, liver and kidneys. So here we have to understand that now compensatory mechanism is not working and body is trying hard to do the blood volume restoration, but it is not able to do. So everything here is now going to fail. The sodium potassium pump will be failed. There will be increased permeability. There will be anaerobic respiration and severe lactic acidosis. The myocardium will become weak because of the reducing output. Hypotension will worsen and blood pressure will drop significantly. So this is a hallmark sign of the progressive stage. There will be increased capillary permeability. Fluid will shift out of the circulation. That is, patient will exhibit the signs of ascites, edema. There will be severe hypotension, rapid weak thready pulse, cold mottled skin, absent bowel sounds, oliguria or anuria due to kidney failure, and lethargy, confusion or unresponsiveness due to brain hypoxia. So there is the progression of the hypovolemia and all the signs and symptoms we are going to see here. And last is the refractory, that is irreversible stage of shock. So this can be a question that what is the irreversible stage of shock? So this is refractory. At this stage, shock is irreversible and the organ damage is permanent. Death is imminent despite aggressive treatment. So everything we will do, immediate interventions will apply, but still the reversing of this condition will be not possible, or at 1% it will be possible. So this prolonged tissue hypoxia will lead to irreversible cell death and organ failure. Heart failure will occur and there will be decreased and in cardiac output and worsening of the hypotension. Brain ischemia we will see. So patient will go into the coma. Widespread clotting will occur, which is known as disseminated intravascular coagulation. So as there will be lots of hypovolemia, so all the clotting factors will be decreased and there will be massive bleeding. Severe metabolic acidosis will develop, leading to respiratory failure. In this condition, there will be profound hypertension. BP will be not able to measure. So we will not able to measure the BP. There will be absent or very weak pulse. There will be severe metabolic acidosis. So this patient will exhibit the sign of cosmos respiration or respiratory failure. There will be complete kidney shutdown. So there will be anuria, unresponsive, coma or death. So the correct answer is D. So now moving back to the question. So as our question was that at what stage of shock the body is trying to attempt to utilize hormonal, neural and biochemical response, so that will be compensatory stage. So option number D is the correct option. Now moving on to the next question. A patient with severe burns and dehydration is being monitored. Which assessment finding requires the nurse's immediate intervention? So in this question, we have to tell that a patient is being monitored for dehydration and severe burns. So what we need to assess that need an immediate intervention. What is the sign and symptom the patient will show that needs immediate intervention? The heart rate of 120 beats per minute. Option B, systolic blood pressure of 110 mercury. Option C, capillary refill times of 2 seconds. And option D, urine output of 40 ml per hour. So what could be the correct option? Now, option 1 says heart rate of 120 beats per minute. So we can see here that this indicates tachycardia. So more than 100 beats per minute of heart rate is tachycardia. So this is an early warning sign of the worsening shock. So this sign or this symptoms can indicate that the person needs immediate intervention. If this is left untreated, it may progress to hypotension and organ failure. Second option says systolic blood pressure of 110 mmHg. Now, systolic blood pressure 110 is normal, but if it is less than 90 mmHg, so that will be alarming. So this is normal. Option C says capillary refill of 2 seconds. So it is also normal. Delayed refill is more than 3 seconds, that will be concerning. Option D says urine output more than 30 ml per hour, which is also within normal limit. If the output was less than 30 ml per hour, that will be alarming. So option number A, that is heart rate of 120 beats per minute, is the sign that the nurse will assess and the immediate intervention will be needed. Moving on to the next question. Which statements are incorrect about the compensatory stage of shock? So we have discussed about the stages of shock and we have to tell that which is the incorrect statement about the compensatory stage. So what was the compensatory stage? In compensatory stage, we have seen that our body is trying hard to reverse the condition. So this stage is reversible. So option 1 says this stage is reversible, which is correct. Option B says during this stage blood is shunted away from the kidneys, lungs, skin and GIT system to brain and heart, which is true. Our body will try to pull blood from the non-vital organs to the vital organs. Option C says during this stage blood flow to the kidneys is reduced, which causes the kidney to activate the RAS system, and this will lead to major vasodilation in the arterial and venous system. Now, in this statement, we can see that renin-angiotensin-aldosterone system will be increased, but it will not lead to vasodilation. Rather, it will lead to vasoconstriction, as the patient is in hypotension. So we need to increase the vasoconstriction and RAS will be helpful to increase the vasoconstriction. So here this thing is incorrect. Option D is one hallmark sign of the stage is that there is an increase in capillary permeability, which is true, as the blood will leak from the capillary, so there will be extracellular movement of the fluid. Option E, a patient is at risk for paralytic ileus during this stage. So we will see that option number C and D are the incorrect about the compensatory stages. Now here we have to see that why option number D is not correct. as capillary permeability increases, but this will not increase in the compensatory stage. It will increase in the progressive stage. Okay, so in compensatory stage, the RAS will be activated, the SNS will be activated, the blood will move from non-vital organs to the vital organs, but capillary permeability will increase in the progressive stage. Therefore, option number C and D are not correct. Now next, the question is, a patient has just undergone abdominal surgery and is now 1 hour post-operation. During the procedure, the patient lost 20% of their blood volume and is exhibiting signs of hypovolemic shock. Which of the following positions should the nurse place the patient into optimized perfusion? So here, the question is that what is the position that is best for the patient when the patient is exhibiting signs of the hypovolemic shock? Option number 1 is place the patient in the modified Trendelenburg position with legs elevated. Option B, position the patient in the Trendelenburg position with head lowered and legs elevated. Option C, position the patient in a high Fowler's position with the upper body elevated at 60 to 90 degrees. Option D, position the patient flat in a supine position with no elevation of the legs. Now we have to understand the mechanism. We have to understand that which position is effective here. So as the blood volume low in the body and we want the blood to move into the heart so that there will be a good cardiac output. So it means that we want a good venous return. And when we want a good venous return, we have to always and always elevate the legs. So leg elevation is very, very important. Now let's see what is Trendelenburg position. So in Trendelenburg position, head is being lowered and the legs are elevated. So yeah, legs elevation will help in the venous return. But now this was historically used to treat shock. Nowadays, in the recent evidence, it suggests that this position does not effectively increase venous return as intended and may even increase ICP. So when the head end is being lowered, it can raise the intracranial pressure, it can compromise the ventilation, and it can impair perfusion to the brain and vital organs. That's why head being lowered is not a good idea in recent times. Now let's talk about modified Trendelenburg position. In the modified Trendelenburg position, the patient is positioned supine with the legs elevated at approximately 45 degrees. So yes, leg elevation is present here and the head end is in supine position. Now this position facilitates venous return to the heart by enhancing the preload, which helps increase cardiac output and tissue perfusion. But the head end is in supine position, so it will not cause any ICP or any compromise in the ventilation. Therefore, it addresses the low blood volume in the case of hypovolemic shock. So this is a good position to be used. Talking about high Fowler position. High Fowler's position with the upper body raised at 60 to 90 degrees. It is not beneficial in hypovolemic shock. This position can decrease venous return to the heart because legs are not elevated, so there will be a lowered venous return to the heart. It can increase the risk of postural hypertension because patient is in hypotension, so it can increase the risk. It can worsen the patient condition as we want to improve the circulation. Raising the upper body too high can also impair diaphragmatic movement, limiting efficient breathing. So we do not need to give high Fowler's position, and we have just to make patient lie down in supine position. Fourth option is supine position. The supine position with no elevation of legs is insufficient for promote optimal venous return in cases of hypovolemic shock. So supine position may be a good position, but it is not helpful in improving the venous return. It can prevent further blood loss, but it is not helpful to improve circulation and to increase preload for better cardiac output. So the option number A is correct, which mentions modified Trendelenburg position. So here we can see modified Trendelenburg position given to the patient is the good idea. Now moving on to the next question. A 35-year-old male is brought to the emergency department after sustaining multiple long bone fractures and a severe abdominal injury. The patient appears anxious with the following vital signs. So here is a patient who is 35 years old, and patient is brought to emergency because patient has multiple long bone fractures and a severe abdominal injury. So we can guess that patient has a huge amount of blood loss and patient is anxious. So the vital signs are blood pressure is 70/54, which indicates hypotension. Heart rate is 125 beats per minute, which indicates that it is tachycardic condition. Respiration is 30 beats per minute, which indicates tachypnea. Oxygen saturation is 96%, which is on 2-liter nasal cannula. That means that oxygen level in the blood is not that much good. Temperature is 99.3, and this indicates hyperthermia. Pain level is 6/10. Upon examination, the skin is noted to be cool and clammy. Given these findings, what is the nurse's immediate priority? Now, from all these signs and symptoms, we can suggest that patient is having hypovolemic shock condition. Now, what is the immediate priority action for this patient? Option number 1 says request a urine sample to assess renal function. Option number 2 says perform a 12-lead electrocardiogram to evaluate cardiac status. Option 3 says initiate 2 large bore intravenous access site for fluid resuscitation. Option number 4, apply a warming blanket to address the patient's temperature. Now let's discuss each option one by one. Option 1 says request a urine sample. Now, investigations are important, no doubt, but it is not an immediate intervention. We need to assess the kidney function, but it is not an immediate intervention for fluid resuscitation. So it do not address immediate need for fluid resuscitation. Option B says perform 12-lead EKG to evaluate cardiac status. Now, EKG is important to monitor the cardiac function, but it is same like option number 1. We will not do it as a priority. The first priority is to start the fluid as soon as possible. Option C says initiate 2 large bore IV access site for fluid resuscitation. Now we can see patients having multiple fractures and internal injuries, which can result in significant blood loss externally and internally, leading to a decreased circulating blood volume. So we have to put large bore IV, that is 18 gauge or higher, to administer fluids, medications and blood as needed. Therefore, it is our first priority to access the patient with IV for fluid resuscitation. Option number 4 says apply a warming blanket to address the patient's temperature. Yes, it is important to look at the patient's hypothermic condition. We need to provide warmth to the patient as patient is having fever, but it is not a priority here. As patient is having severe conditions like patient is having 125 beats per minute heart rate, BP is dropping very much. So our first priority should be restoration of the fluid. So option number C is correct. Next question is, during an in-service training for a newly graduated nurses, you discuss fluid resuscitation strategies for hypovolemic shock. You ask the participants to identify which types of IV fluids are classified as crystalloids for this condition. Which of the following responses are incorrect? So in this question, we have to identify that what are the crystalloids. Okay, so we have to find the incorrect option, which means which of the following are not crystalloids. Option number 1, albumin. Option number 2, lactated ringers. Option number 3, normal saline. Option number D, hetastarch. So from among these, which are not crystalloids? To solve this question, we have to differentiate between colloids and crystalloids. So what are the colloids? Colloids are the larger molecules. So there is a huge difference between colloids and crystalloids. Colloids contain large molecules, whereas crystalloids contain small molecules. Large molecules that exert osmotic pressure. So they have an osmotic pressure which help retain fluid in the bloodstream. So whenever we give colloids, it helps in retaining the fluid in the bloodstream, and it helps in stabilizing the fluid volume, and it increases the fluid volume. Examples are albumin, blood products, hetastarch, fresh frozen plasma, etc. Whereas crystalloids are the smaller molecules that can across the membranes, and they may require larger volumes to achieve the same volume of expansion. Now here we can see that colloids are larger molecules, so they will be given in the less amount and they will be effective in less amount, whereas crystalloids are given in large volume to expand the fluid volume. So crystalloids are crystal clear, that's why they are named as crystalloids. When any fluid is crystal clear, it means that it has small particles. But when any fluid is not crystal clear, it is opaque, it means that it has large molecules. That's how we will differentiate between colloids and the crystalloids. Now, from which of the following it is not crystalloids, which means from these following, what is the colloids? So albumin is the colloid and hetastarch is the colloid. RL and normal saline are crystalloids. So option number A and D are the correct option. Now moving on to the next question. Which of the following statements accurately describes the properties and clinical considerations of colloid solutions? Select all that apply. So we have to tell what is true about the colloid solutions. Option A, colloid solutions consist of large molecular components that are too large to pass through capillary walls, thereby helping to retain fluid within the intravascular compartment for a longer period than crystalloid solutions. So this is true about the colloid. They are large molecules, they are not easy to pass through the capillary walls, and they help in retaining fluid because they have osmotic pressure, and they stay longer period of time than crystalloid because they have large molecules. Option B says due to their smaller molecular size. So here this is incorrect about the colloids. They don't have smaller molecule, they have larger molecular size. Colloid solution easily crosses the capillary membrane, which is wrong. It does not easily cross the capillary membrane, leading to a more transient effect within the intravascular space compared to the crystalloid solution. So this is not correct. Option C says nurses should be vigilant for signs of allergic reactions, including anaphylaxis, when administering colloid solution. Now we will discuss in the next PPT that why we have to look for the allergic signs in the patient having colloid solution. So this is also true. Now why it is true? Because colloids may contain proteins or other substances that can trigger an immune response. So we have to always closely monitor the adverse reaction like the signs of hypersensitivity while administering these solutions. So colloids contain large molecules such as proteins, starches, gelatins. They cannot easily pass through the capillary walls. They remain in the intravascular space longer than the crystalloids and they expand the blood volume more effectively. Whereas crystalloids have small molecules, they can easily cross the membranes and they require larger volumes to achieve the same volume expansion. So option number C is correct for colloids because we have to vigilantly monitor the signs of allergy. Option D says colloid solutions are classified as hypertonic fluids which draw fluid from the interstitial space into the blood vessels, raising the risk of fluid overload. So this is not true. Colloid solutions are not hypertonic. So hypertonic fluids, what are the hypertonic fluids? They pull fluid from the compartments, but the colloids are helpful to retain the fluids, to not pull the fluid. They retain the fluid in intravascular space. The osmolarity of colloid solutions varies depending on the type, but they are typically not labeled as the hypertonic solution. So option number A and C are correct. A nurse is caring for a patient receiving aggressive fluid resuscitation due to hypovolemic shock. Which of the following interventions should the nurse prioritize to ensure the best outcome? So as the patient is in hypovolemic shock and nurse is caring for the patient, the aggressive fluid resuscitation is going on. So what is the priority for this patient? Option A. Administer fluids as quickly as possible to restore fluid volume rapidly. Option B. Ensure the fluids are warmed before infusion to prevent complications. Option C. Change the infusion tubing between fluid bags to prevent contamination. Option D. Position the patient in a supine position for optimal fluid distribution. So what is the priority of nurse here? So let's talk about option number 1. That is administering fluids as quickly as possible to restore fluid volume. Now rapid fluid administration is very important. But too fast infusion of fluid without considering temperature can lead to hypothermia. So always infuse rapid fluid but consider temperature of the patient. So whenever we receive a fluid that is a colloid or crystalloid, that should not be too much cold. As patient has low volume of fluid in the body, so patient is already in hypothermia. And for that patient, giving a fluid which is having a low temperature can lead to further complications. Now what are the complications that can occur? Because the fluid can be cold, it can lead to the impairment in the clotting function and enzyme activity. Now option B says ensure the fluids are warmed before infusion to prevent complication. So why the fluid should be warmed? Fluids should be at optimum temperature before administration. Cold fluid can cause hypothermia and it impair clotting function and enzymatic activity of the blood. And we have to ensure that the fluid is not that much warm. We don't want the person to burn. So the fluid should be at optimum temperature. Preventing hypothermia ensures better coagulation and immune function. So it is a very crucial point for the patient having hypovolemia that when the fluid is rapidly infused, we have to always check the temperature. Option C says change the infusion tubing between fluid bags to prevent contamination. Now, maintaining sterility is very important, but during the rapid infusion of fluid, if there is no necessary condition, then we don't need to change the tubing unless there is a risk of contamination or line is occluded. So, unnecessary don't change the tubings. If there is any line occlusion, only in those cases we have to change, otherwise it is not a priority. Option D, position the patient in a supine position for optimal fluid distribution. Now, positioning the patient is very important, but it is not an immediate intervention for ensuring adequate fluid restoration with optimum temperature. So, our priority will be restoration of fluid, temperature of the patient, and we have to look for the we have to look for the hallmark signs, but all the other cares are not the priority here. So option number B, that is warming the fluid before administration, is the correct option. Next question is, a patient in hypovolemic shock is experiencing significant blood loss and requires support for clotting. Which type of fluid should the nurse administer to address this need? Now, the patient is in hypovolemic shock due to the blood loss, and due to the blood loss, patient needs the clotting support. So which is a fluid that is very important and it is very useful for providing clotting factors? Option number 1, platelets. Option number 2, albumin. Option number 3, fresh frozen plasma. Option number 4, packed RBC. So talking about the platelets. Platelets are given when there is low platelet count. You will be confused because platelets are helpful in clotting, but it do not directly provide the clotting factors. It helps in initiation of the clotting formation, but will not address deficiencies in the broader clotting cascade. Not necessary for patients needing clotting factors in the shock or massive blood loss. So platelets is not a good idea to replace the clotting factors. Option B is albumin. Albumin is a volume expanding colloid. It is useful for fluid resuscitation but is not helpful in providing any kind of clotting factors. Option C is fresh frozen plasma. Now, fresh frozen plasma contains all the coagulation factors such as fibrinogen, prothrombin, and other clotting factors. It is a fluid of choice when the patient requires clotting factors. So whenever there is blood loss, there will be hypovolemia. We have to provide fresh frozen plasma to provide clotting factors to stop the hemorrhage. Option D is packed red blood cells. Now, red blood cells are very important because they contain the oxygen carrying capacity and they will help in providing oxygenation and will help in patient from recovering anemia, but it do not address the bleeding issue caused by any clotting factors. Therefore, the option number C, that is fresh frozen plasma, is the correct option. Last question of this video is, which of the following intravenous solutions are not classified as colloids? So we have to find out which one of the following are crystalloids. Select all the options. So multiple options we have to select that are true regarding the crystalloids. First is fresh frozen plasma. Now, fresh frozen plasma is opaque. It is a colloid. It contains large molecules. Albumin. Albumin is a protein. It has large molecules. It is also a colloid. Normal saline. Normal saline we have used in our hospitals, which is crystalloid because it is crystal clear and it has small molecules. Lactated ringers. Lactated ringers is also a crystalloid. Heta starch. Heta starch contains the starch. It is a colloid. And platelets. Platelets are also the colloids. Now we have discussed earlier that colloids are the larger molecules and crystalloids are the smaller molecules that can cross membrane easily. Fresh frozen plasma is a colloid. It is primarily used to increase clotting factor levels and expand blood volume. As a blood product, it is rich in proteins like albumin, which contribute to its colloidal nature, exerting osmotic pressure in the vascular system. Albumin. It is also a colloid solution. It is used to expand blood volume and maintain oncotic pressure. As a protein solution, it stays within the intravascular compartment, helping to restore blood volume in the patients with hypovolemia. Option C is heta starch. It is also a colloid solution. It contains synthetic starch molecules. It helps to maintain intravascular volume by exerting osmotic pressure, which pulls water into the vascular space. Option D is platelet. It is a colloid because they are cellular components. When transfused, they stay within the vascular space for clotting and volume support. Platelets are not a fluid like other colloids. They act similarly in terms of volume expansion and osmotic pressure. So option C and D are correct because both of them are crystalloids. So this was all about the topic hypovolemic shock. I hope that I'm able to help you in understanding this topic. Thank you.